Good evening, everyone. My name is Cheryl Yates, and I will be presenting part 2 of my presentation called lower back pain. I will be defining lower back pain and talking a little bit about the epidemiology involved. I will also be discussing the scales and grading. I'll touch again on the intervertebral disc and disc displacement, since it is one of the things that attributes to lower back pain. How we work up someone who comes in with lower back pain, focusing on the history, the physical examination, and buzzwords or red flags that we should look out for. Then I will focus on the radiographic evaluation and something called electrodiagnostics for low back problems or lower back pain, and the conservative treatment of lower back pain. So lower back pain is said to be the pain between the lower edge of the ribs and the buttock. And a few terms that we hear very often associated with low back pain, or when we get referrals from A&E, are radiculopathy, which deals with the dysfunction of nerve roots. And signs and symptoms, as I would have discussed before, would include pain in the distribution of that particular nerve root, weakness of muscles innervated by that nerve root, etc. We may also hear mechanical low back pain or musculoskeletal pain, as we call it. And this is actually the most common form of low back pain. The most common form of low back pain. It actually may result from paraspinal muscles or the strain of the paraspinal muscles or ligaments or irritation to facet joints. And then another word that we hear very often is called sciatica, which is where you have pain along the course of the sciatic nerve, and is usually resulting from nerve root compromise. Can we pause the video for 1 second, if that's possible? So as I was saying, a term that we have very common is also sciatica, and that's why I said you have pain along the course of the sciatic nerve, and it's usually resulting from the nerve root compromise. And we know the sciatic nerve is composed of the nerve roots L1 to S3. Now, 690 million people live with lower back pain, and it has the highest prevalence globally among all the musculoskeletal conditions. It is leading in 2 areas, or is most common cause of disability worldwide, as well as it's the cause of disability for persons below the age of 45. It's the second most common cause for loss of time at work, with approximately 15% of all sick leave from work. And it's also the second most common reason for people to seek medical attention. The estimates of lifetime prevalence of low back pain range from 60 to 90%, with an annual incidence of at least 5%. We can describe low back pain as acute versus subacute versus chronic, or we can group it as specific or non-specific, with 85% of the cases being non-specific. However, in these specific cases, at least 1% of patients will have nerve root symptoms, and 1 to 3% will have lumbar disc herniation. The prognosis for most cases of low back pain is pretty good, with at least 89 to 90% of patients showing improvement within 1 month, even without any sort of treatment. In terms of scaling, so the development of tools to measure the outcome of patients with low back pain has become a subject of interest, increasing interest actually, for research purposes, particularly for clinicians to justify the effectiveness of or their interventions. The intensity of low back pain is usually evaluated by 1, a visual analog scale or VAS, a numerical rating scale, or a disability scoring system such as the, forgive my language, Oswestry Disability Index or ODI, the Roland Morris Disability Questionnaire, and the short form 36. However, the use of these established rating systems doesn't always or does not fully evaluate the characteristics of low back pain. So the first one I'll talk about is the visual analog scale, or the VAS. And this is what we essentially use when we're asking patients to rate their pain. But particularly for low back pain, we talk about pain while the patient is in motion, low back pain when they're standing, or low back pain when they're sitting. And we ask the patient to mark their pain level on line, as you can see on the screen, divided into segments, which unfortunately was a poor diagram, but it's divided into segments from 0 being no pain or little to no pain, and 10 being the worst pain that you would have ever experienced in your life. Then we have the ODI, and this is a categorical ordinal scale that consists of at least 10 questions. I hope you can see them on the right. Yeah, let me see if I can zoom in. Each item, so it consists of 10 questions related to activities of daily living, and each item is scored from 0 to 5, with 5 being the most disability, and the total is multiplied by 2% to obtain the final score. So let me zoom back out so we can appreciate the scoring system. Yeah, to your bottom left. The interpretation of the final score, as I said, you can see on the left. A score greater than 45% is essentially completely disabled, and a score in the teens is very functional. So we can see on the left-hand side, 0 to 20 is minimal disability, and the patient can actually cope with daily activities. However, someone who has 41 to 100% can range from severe disability with other areas affected, or these patients are particularly bedbound or else exaggerating their symptoms. Next, we have the Roland-Morris Disability Questionnaire. Now, in 1983, the original questionnaire was used to measure self-rated immobilization resulting from low back pain or back pain. It was designed, as I said earlier, particularly for research as an outcome measure for clinical trials. But it has been found to be very useful in monitoring patients in clinical practice and primary care, particularly in the United Kingdom. It is formulated by choosing statements from the Sickness Impact Profile, or SIP, which is actually a total of 136 health status measure, 136 item health status measure covering a wide range of aspects of daily living activities related to physical and mental function. The items of the questionnaire are mainly related to physical activities, as I said, in order to assess the disability caused by chronic or lower back pain. And it's either a yes or no question, and it can be administered, yes or no answers, and it can be self-administered to the patient, and they can complete it within 5 minutes. So you have questions of, I stay at home most of the time because of my back, or I find it difficult to turn over in bed because of my back. Then lastly, but lengthy, we have the short form 36. So health-related quality of life, or HRQOL, is a multi-dimensional concept comprising of domains of physical, social, and mental well-being, as well as functional ability. It is actually considered the most used generic instrument, and it's internationally validated by the medical outcome study. The SF36, or short form 36, is increasingly useful for monitoring health populations as a tool for decision-making on healthcare policies and medical interventions. So you have the questions from 1 to 11 on this side, and these would be your response choices. So let's say, for instance, question 2, compared to 1 year ago, how would you rate your health in general now? And you go to question the second response choice here, and you choose either much better now than 1 year ago, somewhat better now than 1 year ago, etc. So in my previous presentation, I would have touched on the intervertebral disc, but I'll just touch on it again, right? Particularly for lower back pain. So adjacent vertebrae articulate through the zygapophyseal joints between the respective superior, so that'll be on top here, and inferior facets of the vertebral articular processes, as well as through the joints of the vertebral bodies. While the former serves to limit the spine's range of, well, I'll do like this actually. Yeah. So this it serves to limit the spine's range of motion. The latter actually increases it and provides majority of the spine's weight-bearing capacity. The inferior surface of the superior vertebral body articulates with the superior surface of the inferior vertebral body through what we call intervertebral discs. These discs also provide shock absorbing effect within the spine itself and prevent the vertebrae from grinding together. They consist of 3 major components: the inner or nucleus pulposus, which I'll be referring to as the NP, the outer annulus fibrosus, or AF, and the cartilaginous end plates that anchor the disc to adjacent vertebrae. The NP is a gel-like structure that sits at the center. So here, for instance, label number 3, that sits at the center of the intervertebral disc and accounts for much of the strength and flexibility of the spine. The annulus fibrosus, or AF, is a ring-shaped, as you can actually see some of the lamellae here, a ring-shaped disc of fibrous connective tissue that surrounds the nucleus pulposus. This structure is highly organized, and it consists of at least 15 to 25 stacked sheets or lamellae, as I said earlier. Would you stop it? Sorry, predominantly collagen, which are uniformly oriented in a plane that differs in orientation to the adjacent lamellae of about 60%. This alignment, as you can see down where the cursor is, it leads to the parallel orientation of the alternate laminae. This radial ply formation actually provides exceptional strength compared to an entire longitudinal setup that has actually been mimicked by the construction of products such as car tires. The lamellae are interconnected through translamellar bridges, and the AF contains an inner and outer portion, as you can also see here. And they differ primarily in their collagen composition. So if you look on the left-hand side, you have a cadaver specimen of the intervertebral disc. Number 3 is the nucleus pulposus. Number 4 is the superior cartilaginous end plate, or CPEP, or CEP, sorry. Number 5 would be the inferior CEP. Number 8 would be the posterior annular fibrosus, or AF. Number 9 being the spinal cord. Now you have 5A and 4A, which would be the inferior and superior, respectively, the inferior and superior ring apophyses, where the AF actually inserts into the vertebral body. And then number 1 is the outer annular fibrosus. Annulus, sorry. So a number of things can happen to the intervertebral disc, and I'll go through each one individually. So firstly, we can have annular tears or annular fissures. When you have increased stress on the annulus fibrosus, or the AP, this could actually lead to some cracks or cavities, and subsequently leading to clefts and then fissures. The loss of this AF structural integrity may result in disc herniation, which I mentioned last week. And when you have this weakness as well, the disc lose the inability to maintain that anatomical alignment and position, progressing to instability and or spondylolisthesis. All the structural changes, so the tears and the fissures, are actually irreversible because adult discs have limited healing potential. Now, the fissures in the AF can actually be circumferential, peripheral, rim, or radial, which I have on the screen. And they usually occur during excessive loading on the spine. And the acute version of the fissures may actually present with pain. So if you look on your right-hand side, so where the arrows I highlighted, the circumferential fissures, the radial fissures, and the peripheral rim fissures. The picture A and B shows the circumferential fissures, and the drawing actually, a drawing and an axial T2 weighted scan at L4, L5. And at the arrow, it's showing the fissure itself. And if you look at the drawing, it shows the rupture of the transverse fibers without disruption of the longitudinal fibers. When you compare to C and D, you have the radial fissures. And the drawing, this is a drawing and this is a CT. The drawing would show the fissure, the radial fissure, extending from the periphery of the annulus to the nucleus, so in this direction here, with disruption of the longitudinal fibers. And then lastly, you have the peripheral rim fibers, where we have a drawing again and a sagittal T2 weighted scan of the L4, L5. And this is showing disruption of Sharpes or Sharpies fibers, if you're a Disney Channel fan like myself, at the annular periphery. Now, what are these fibers particularly? We also call them perforating fibers or bone fibers, and they're just bundles of collagen that connect the periosteum to bone. Then, as I mentioned last week, we have the degeneration or degenerative disc disease. And in degenerative disc disease, it's just a clinical syndrome of the symptoms particularly desiccation, fibrosis, narrowing of the disc space, etc., that leads to the radiculopathy and the changes that we would have, the symptoms that patients usually present to our clinic with. Then you have bulging and herniation, which we can group together as disc displacement. So a bulging disc is basically when you have the protrusion, the outward protrusion of the outward layer of the annulus, and that annulus actually remains intact. However, because the disc protrudes into the spinal canal, it can actually still compress a nerve root. Another term that we use sometimes is called disc prolapse. Now, when a disc herniates, the soft nucleus splits out through a tear in the annulus. And because there's limited space within the spinal canal, the nucleus can actually compress the nerve root or the spinal cord. The nucleus also can extrude into the spinal canal, the foramen, or on either side of the disc, or in some rare cases, multiple places, called multifocal extruded disc. They are more common in the lumbar region, and some other terms that we use to describe them, or what patients would usually come and say, is a slip disc, and we would also call it a rupture disc or extrusion, or disc extrusion, sorry. So I would have shown this image lastly, but I'll briefly touch on it, that you have at least two types of disc displacement. You have diffuse, which would include the disc bulging and the annular bulging. Then you have the focal herniations, where you have the protrusion, extrusion, and the extrusion with sequestration. With the disc herniations, they can either be on an axial plane or sagittal plane. If it's on an axial plane, and even though axial divides into superior and inferior, the images we're looking at would let us know if it's anterior or posterior. If it's posterior, it can either be central, paracentral, foraminal, or extraforaminal. If we're looking at the sagittal plane, which usually divides the image into the left or the right, it can be either superior migration or inferior migration. This is just another image to show the different herniation zones. The paracentral zone can also be called the subarticular zone. So when we are assessing a patient who is coming in with back pain, and as Dr. Bartley would have mentioned, we would make sure and stabilize the patient first following on our ABCDs, and we move on to assessing the patient with asking them about their history. We would ask about the patient's age, as I would have mentioned in the epidemiology, that it's the most common cause of musculoskeletal pain, particularly in persons below the age of 65. So be younger than 45. So anyone greater than 45, we start to think of a couple more things. If they have a history of cancer, particularly malignancies that are prone to skeletal metastases, so like prostate, breast, kidney, thyroid, lung, or even myeloma. If the patient has unexplained weight loss, which actually goes hand in hand with the history of cancer. If the patient is on any form of immunosuppression, like it could be for steroids, organ transplants, or even for patients who are retropositive. If they have a prolonged use of steroids, if they, the duration of their symptoms, so going back to if it's acute or if it's chronic, responsiveness to previous therapy. So I would have mentioned for degenerative thoracolumbar disease that we can conservatively manage that patient first. So if they're not responding to that, we want to know what was done, if they had done physiotherapy, had they taken any analgesia, whatnot, and had they been responsive to it, and what is the change now. Pain that is worse at rest, a history of skin infection, particularly like furuncles, history of IV drug abuse, any UTIs or other infections, particularly UTIs in women, or UTIs that tend to extend within, forgive me, I'm forgetting my jargon. Pain radiating below the knee, persistent numbness or weakness in the legs, any history of significant trauma, so that could include MVAs or any form of direct load to the back, any fall, or any heavy lifting, which is something very common that we see. Even severe coughing, severe persistent coughing. Findings consistent with Corday-Quiner syndrome, which I will touch on a little later, but I will mention, because we've had at least 1 to 2 patients within the last couple of months presenting with a form of caudate equina syndrome, and they would have had either bladder dysfunction, and it's usually urinary retention, or overflow incontinence or fecal incontinence, saddle anesthesia, or unilateral or bilateral leg weakness or pain. And then lastly, psychological or socioeconomic factors. So that could include people who basically want to either avoid work if they are unable to perform typical job tasks, or want to avoid it, their educational level. So that actually would deal with how well they understand what's going on with them and whatnot. So in terms of the initial assessment, we now will focus on the physical examination. So on the right-hand side, I include the myotomes and the dermatomes for the lower limb. So if we're thinking of the patient says that they have lower back pain, and we want to think maybe this is a spinal infection. Some things we should look out for is if the patient has a fever. Fever is very common in epidural abscesses and vertebral osteomyelitis. It is less common in discitis. If they have any vertebral or paravertebral tenderness, and if they have a very limited range of spinal motion. If the patient is having some form of neurologic compromise. Now, the physical findings that I'm going to mention is oftentimes most cases of clinical significant nerve root compression due to L4 to L5 or L4-5 or L5 to S1 herniated lumbar disc. And this actually comprises of more than 90% of the cases of the patients who talk about HLD present with radiculopathy. So firstly, it's not saying that all patients would present like this, but this is actually most common. So dorsiflexion strength of ankle and great toe is actually weakened, and it actually suggests an L5 and some L4 dysfunction. Then the patient may have a diminished Achilles reflex, and this would actually suggest an S1 root dysfunction. Just trying to pinpoint it when I talk about it. If they have light touch sensation of the foot that's diminished over the medial malleolus and the medial foot, that actually would also suggest a L4 nerve root involvement. If it's diminished over the dorsum of the foot, that's an L5. And if it's diminished on the lateral malleolus and lateral foot, that suggests an L1. And the patient may actually have an positive straight leg raising test or crossed straight leg test. So as I mentioned earlier, there's certain red flags or clues that us clinicians should look into or have ringers go off when we hear the patient talk about it or we find these things in our examination. So when the patient, as I said, be above the age of 50 or 45 or less than 20 years of age, if they have a history of cancer, and as I said, that correlates with an unexplained weight loss, if they have some form of immunosuppression, so if they're on cancer treatment or treatment for retropause patients, history of UTI, IV drug abuse, fever or chills, and the back pain that is not improved with rest, we think of cancer or infection. If the patient comes in and has a history of significant trauma, prolonged use of steroids or above the age of 70, we are thinking a spinal fracture. Now, if the patient's symptoms are acute onset, and as I mentioned before, acute urinary retention or overflow incontinence, fecal incontinence or loss of anal sphincter tone, saddle anesthesia, or global or progressive weakness in the lower extremities, then we're thinking a caudate equina syndrome or severe neurologic compromise. So how do we examine patients radiographically who complain of lower back pain? Diagnosing the lumbar stenosis particularly, or a herniated intervertebral disc, is very helpful by use of x-rays. And it's very helpful only in potential surgical candidates. This includes patients with appropriate clinical syndromes who have not responded satisfactorily to adequate non-surgical treatment over a sufficient period of time, and who have no medical contraindications to surgery. So the radiologic confirmation of these diagnoses usually include x-rays, CT scans or MRIs and or myelography, or sometimes a combination of both. Now, X-rays. X-rays are really good in showing or diagnosing congenital abnormalities of unsignificant, of uncertain significance, particularly spina bifida occulta, and it actually shows some evidence of degenerative changes, including osteophytes. We reserve lumbosacral X-rays, particularly for patients with a likelihood of having a spinal malignancy, infection, inflammatory spondylitis, or clinically significant fracture. In these particular cases, plain X-rays are often just a starting point to further study like a CT or MRI may be indicated, even if the plain X-rays are normal. Another use of X-rays for lumbar spine or in patients who complain of lower back pain are the flexion and extension lumbar X-rays. And these lateral X-rays are taken with the patient first in a neutral position, and then when flexing forward at the waist, then with hyperextension at the waist, it may actually demonstrate dynamic instability. Then we have oblique X-rays, which will actually show or demonstrate spondylosis as a fracture in the neck. And what we will learn in medical school, forgive me for not putting the image, but the Scotty dog appearance. And then for patients who the standing scoliosis X-ray, and this is just used in primary indication in the preparation for surgical intervention. So CT scans. CTs can actually demonstrate most spine pathology. For herniated lumbar disc particularly, sensitivity is 80 to 95%, but the specificity is low at 68 to 88%. However, even some large disc herniations can actually be missed on plain CT. CT studies for particularly HLDs tend to be less satisfactory in the elderly. When MRI is an option, the main utility of CT is literally for imaging bone to assess fractures or to demonstrate details of bony anatomy for surgery. On this screen, it's showing a CT scan of the lumbar spine, particularly herniation of the L4-5 disc migrating downwards or inferiorly, that circled on the left. And then if we look at the image on the right, it's actually paracentral to the left. Now, the advantages of taking a CT are that, as I said before, and as you can see, it's excellent for bony detail. It's non-invasive, and it can actually be done as an outpatient. It also has some ability to evaluate paraspinal soft tissue to rule out any tumors or paraspinal abscesses. The advantages of a CT over an MRI is that it's faster, and you would want something that's faster, particularly for patients who have difficulty lying still for a long time. It's actually less expensive and less claustrophobic. The disadvantages, however, is that it involves ionizing radiation, and the sensitivity is actually lower than an MRI or a myelogram CT. An MRI. Unless contraindicated, non-contrast MRI is the initial diagnostic test of choice for diagnosing most cases of disc herniation and spinal stenosis. Specificity and sensitivity for the disc herniations are on the same order as the CT myelogram, which is better than the myelogram alone. The advantages of an MRI is that it provides the most information about soft tissues, so like intervertebral disc, spinal cord inflammation, what have you, of any available diagnostic tests. It provides information regarding tissue outside of the spinal canal, so like if the patient has extreme lateral disc herniation or some tumors, and it's actually non-invasive and does not include or utilize ionizing radiation. The disadvantages, however, is that in patients with severe pain or with claustrophobia, they may have difficulty holding still, which we have a patient on the ward who gave some shaky MRIs because he couldn't remain still. Does not visualize bone well. That's particularly CT, so actually does that. Poor studying for blood, particularly early blood issues, so like spinal epidural hematomas, it's very expensive. And the interpretation with scoliosis is more difficult and may be partially compensated by contouring visualization playing through center of the canal, as well as there are a number of contraindications to patients to receive MRIs. Some other images or radiographic evaluations that we may use the myelography, and that's where you use a water-soluble intrathecal contrast that is introduced via lumbar puncture. It has a sensitivity of 62 to 100% and a specificity of 83 to 94%, which is similar to a CT for detection of a disc herniation. It's usually combined with post-myelographic CT scan, which increases the sensitivity and especially the specificity. A herniated disc in the large space between the thecal sac and the posterior border of the vertebral bodies at L4, L5 particularly may not be seen on myelography alone, which again, now CT and MRI are usually better at this. But what the myelography can be used for is for the evaluation of the evaluation of the chordae equina is better than a non-contrast CT. Unfortunately, the myelography may miss pathology outside of the dura. It is very invasive, and because we're introducing this contrast, we have patients that may have an iodine allergy, and even if the patient doesn't have an iodine allergy but have some form of allergy, they may actually be affected. We also have bone scans, and this is where you have injection of a radio-labeled compound, and this compound is taken up forgive me, I'm cold, metabolically by active bone, and then a gamma camera would localize the regions of uptake. The total radiation dose is equivalent or approximated to the set of lumbar spine x-rays. This can be used to evaluate low back pain when a spinal tumor, infection, or a occult fracture is suspected from the red flags that I would have indicated before on history and examination, or results of a lab test or plain x-rays. It's not very specific, but may actually be able to locate some occult lesions and help differentiate these conditions from degenerative changes. Then we have the discography, and this is where we have the injection of a water-soluble contrast agent directly into the NP or the nucleus pulposus of the intervertebral disc being studied by a percutaneous needle through an access point called Cambin triangle that you can see on the left-hand side, or your right-hand side here. The results of this test particularly depend on the volume of the dye accepted into the disc, the pressure needed to inject the dye, and the configuration of the dye, including leakage from the confines of the disc space. And we usually use plain x-rays to produce the so-called discogram, and that helps us to identify levels that may produce the quote-unquote discogenic pain. Lastly, we have the electrodiagnostics or ED. And if the diagnosis of the radiculopathy seems likely on clinical grounds, you might not need electrophysiologic testing. The one we use the most, or I would say I've heard of in clinic, is the nerve conduction studies. And this actually helps to identify any acute and chronic entrapment neuropathies that may mimic radiculopathy. We also have the H reflex, which measures sensory conduction along through nerve roots. We have the SSEPs, which assesses afferent fibers that travel in peripheral nerve and the posterior column of the spinal cord. You would find that abnormal in conditions like cervical spondylitic spinal myelopathy. We have the H reflex that I mentioned just now, and the needle EMG, which can actually assess acute and chronic nerve root dysfunction, myelopathy, and myopathy. And it's actually useful for patients in suspicion of other conditions, like just a general neuropathy, or when a reliable strength exam is not possible. So in terms of the management, the conservative management of lumbar back pain, I listed education, activity modifications, analgesics, muscle relaxants, and epidural injections. So an initial period of non-surgical management is indicated except in the following circumstances. Situations where conservative management is not indicated is where, as I mentioned, the red flags, so symptoms of chordae equina syndrome, progressive neurological deficit, or profound motor weakness, a relative indication for proceeding to urgent surgery without conservative management is severe, and pain that cannot be sufficiently controlled with adequate pain medication, which again is very rare. So in terms of patient education, I'm a firm believer that educating patients on what may be the possible cause or helping them find what is the cause of their back pain is very important. Most times when patients are in theater, when patients are in clinic and we are going through their day-to-day or asking them to reflect on if they had done anything, we are oftentimes able to identify what may have caused them to have lower back pain. In terms of activity modifications, sometimes we would recommend that patients have bed rest, and some modifications would be to temporarily stop lifting the heavy items, or sitting down for too long, like some clerks would do, and or bending or twisting of the back that you may see in some construction workers. We might actually refer them to physical therapy, where they would do certain exercises and spinal manipulation therapy. Forgive the duplicate of the word. Some analgesics that we would give would be the NSAIDs or the opioids in extreme cases. Some muscle relaxants for patients who have spasms of the lower back muscles, and epidural injections. With the epidural injections, the patient might have some improvement at 3 to 6 weeks, but it doesn't really show that, it does not really negate the patient from being a candidate for surgery. After 3 months, it usually wears off. And that is the end of my second section of lumbar back pain. If I continue on to the surgical management, I don't think I will make the time.